Good afternoon. We've got a full room, it looks like. Hopefully not everybody here is only the people that are presenting, but maybe that's the case. Hopefully we'll get some more people from lost finding their way. My name is Sam Balki, and I am accompanied by Professor Keita Kikuchi and Professor Kazimoglu from Azerbaijan. Everybody knows Dr. Keita from Japan and China. And so we've got a slew of great abstracts this afternoon. I came rushing from Philadelphia just to let you know the patient is doing great, and the recovery has already begun. And so we'll get an update on that patient probably tomorrow from Dr. Torregrossa. So without further ado, let's go ahead and start our abstract session, which is minimally invasive and robotic coronary bypass. Our first speaker is Dmitry Denisyuk from St. Petersburg, the Russian Federation, and the topic is 10-year outcomes in off-pump multivessel minimally invasive coronary bypass via left-sided mini-thoracotomy in over 1,000 patients. Go ahead, sir.
Good afternoon to everyone, colleagues. Can I have presentation, please? My name is Mikhail Svetkin. My colleagues from St. Petersburg can't fly here, and I have this topic. Can I have presentation? So, we've been doing mixed cap currently 214, and this study is kind of summary of 10 years experience. We have no discuss. There's 2025 is made by two great deaths for minimal invasive coronary surgery. In January, we have 16th anniversary of the first clinical practice of pump limit to LED anastomosis via left mini-thoracotomy, which was performed by Kolesov in Leningrad. 20th anniversary is the first clinical practice of pump multivessel coronary artery bypass grafting via mini-thoracotomy, which was performed by Joseph McGinn in the Head Institute of State Island. Multivessel mid-cap is widely discussed nowadays. There are two main questions. How safe and effective and mixed cabbage compared to the full sternotomy approach, and what are the long-term results? The first Lima LED mid-cap long-term follow-up data was published October 2024. You can see on this slide. The first mixed cap long-term follow-up data in 566 patients were performed to 2005 to 2022 years. 40 days mortality was 0.2%. 11 years survival was 82%. This experience demonstrates multivessel mixed cap to be safe and efficacious in long-term periods, but nowadays we don't have quite enough long-term follow-up results. I would like to present our 10 years experience. We investigate 158 patients underwent of pump multivessel mid-cap via left mini thoracotomy. Clinical follow-up data available for 982 patients, and geographic follow-up data was available 245 patients. Our results, our follow-ups. Most of the patients had elective indication for the revascularization, and more than 12% of the patients were operation urgent. The mean graft number was 2.5, median 3. We had 3 cases of intraoperative conversion to sternotomy. The results you can see here. We used CPB support for 14 patients. The CPB support was planned in 5 patients. In 3 patients, due to dilatation, left ventricle with received ejection fraction less 30%, and 2 patients due to acute myocardial infarction and ongoing ischemia. Our case conversion to CPB support were embraced due severe hemodynamic instability. Graft discussion deep in the target vessel was typical. This slide highlights. In all the cases, we used transit. The follow management is intraoperative graft patency control. More than 34% of patients underwent multi-arterial mixed CABG. We are demonstrating typical configuration multi and total arterial grafting, 3D CT reconstruction image. Rate of reoperation for bleeding, transfusion were low. Unindicated of atrial fibrillation was 6%. 10% of patient had complication. No case deep infection. Mean hospital stay was 7.1 plus or minus 1.4 day. 70 patients had hybrid revascularization during the same hospital stay. We had 3 in hospital deaths. The reason demonstrated on this slide. 30 days MACE we can see here. Sorry. As for the follow-up data, we might say we demonstrated our angiographic follow-up. The first 245 patients at ISMIX meeting, all the patients were examined with CT coronarography. To sum it up, a mixed CABG is effective and safe procedure of treatment for patients with multivessel coronary artery disease. Long-term results, mixed CABG are comparable on conversion of coronary artery bypass surgery, and minimal injury contributes to early return to daily life with optimal cosmetic effects. Thank you for your attention.
I think we have time for 1 or 2 questions. Keita, you're the expert in mix
Okay.
this table.
It's a really nice long-term result, I think. And can you tell me what the reason why
Question.
you can obtain a good result compared to the Ottawa University?
Excuse me?
Sorry, you have a good result with 10 years result, right? And you compare your result compared to Ottawa University.
It's for 14th Hospital in St. Petersburg, yes.
Yeah. And what is the reason why you can get a good result, better result compared to Ottawa University?
It's,
Sorry, maybe you use bilateral mammary artery or more multi-arterial grafting for your
Yes.
series?
It's Lima LED and it's grafting at
Maybe bilateral.
Yeah.
Yeah, I think bilateral
Yeah.
brought a good result.
Which once again shows what the importance of
Yeah.
arterial graft.
So even a mixed cavity using multi-arterial graft provide a good long-term outcome compared to single mammary artery and vein graft.
What was in the original McGinn paper, the incidence of bilateral ITA? Do you remember?
Very few.
Very few.
No, actually, the first report they don't use multi-arterial
Just
grafting,
single.
a single one.
Thank you.
Thank you. We are going to next presentation. Total arterial aortic no-touch revascularization in mixed CABG using skeletonized right gastroepiploic artery. Hiroki Sakai and colleagues. But please remember you have 4 minutes for presentation and 2 minutes for discussion. Thank you very much.
Okay, good afternoon, everyone. My name is Hiroki Sakai from Tokyo Bay Medical Center in Tokyo, Japan. Okay.
Yeah.
Just
Can you slides on screen?
Okay.
Yes.
Okay.
Yes.
Today, I'm going to show you our experience about the total arterial aortic no-touch revascularization in mixed cabbage with skeletonized RGA. Next. Okay, you know, a total arterial aortic no-touch complete revascularization is ideal for cabbage, and RGA is an effective third arterial graft where the PDA was significant stenosis in cabbage. But now the real role is unclear, so our aim is to clear how important graft RGA is in mixed cabbage to achieve the goal. I want to show you a demonstration video. In this case, I performed supported by Dr. Keita Kikuchi, harvesting the RGA in a total arterial aortic no-touch CABG. I put 5 centimeter skin incision under the subxiphoid and keep the RGA with basil tape and harvest with scissor-shaped harmonic scalpel from the distal point to the proximal portion. At the same time, I usually take down the bilateral ITA with long shaft harmonic scalpel from the 5 intercostal space, like this. And check the target and check the quality of each graft and trim the RGA and ensure complete hemostasis. In this case, about 30 centimeters of RGA was harvested, and its pulse is so good, and Mirena or papaverine spray on the RGA to prevent spasm. and then make L-shaped incision in the diaphragm to create a route for the RGA. Pull through from the abdominal cavity to the pericardial cavity. After that, I anastomosis the RGA to the PDA by 80 Proin. After the procedure, to prevent the skin incision, I insert the anapain beside the.
He does his case.
I infuse the anapain beside the wound to prevent the postoperative pain. Our team performed over 550 cases in mixed cabbage, including anastomosis of RGA is 2,019 cases. And I compared the 103 cases with RGA. The RGA group was able to achieve total arterial and aortic no-touch revascularization, and its operative mortality was good, so excellent. The number of distal anastomosis per inflow was 1.24 in RGA group, compared with 1.42 in the non-RGA group. The RGA group essentially achieved a one inflow, one territory configuration. The RGA group often does over 3 inflows, while the non-RGA group usually had 2 inflows. Using the RGA made the total arterial revascularization easier because of keeping more 3 arterial inflow. On the other hand, non-RGA groups, non-touch SBG or radial artery tend to be used as an AC bypass to the RGA and circumflex territories. In conclusion, RGA is a reliable third arterial graft in mixed cabbage, enabling total arterial and complete revascularization with ascending out the aortic manipulation. Thank you for your attention.
I have a quick question. What's the advantage right GE over the radial artery? And why do you need using right gastroiliac artery, not radial artery?
The RGA is very important graft because the RGA covered to the PDA. So after all, LAD territory and circumflex territory is covered only by the. So at the end of the configuration, we complete the total arterial revascularization.
I know we can do total arterial revascularization, even no touch aorta, bilateral ITA and radial artery. We can do. What's the reason you choose not radial artery? You choose right gastroiliac artery?
When I use the radial artery, I get only 2 inflows. But if I use the RGA, I have 3 inflows.
So you think that a natural proximal anastomosis is better? A natural proximal inflow is better than man-made? Is that your contention? Yeah, I think that's most of the reason why people use RGA.
Yeah, because I love to do in situ bypass grafting.
Yes.
So my policy is each area should be each inflow
By itself.
So we can do in situ total arterial grafting, and we don't need to touch ascending aorta.
Yep.
And we can do less anastomosis surgery, because if you use composite graft, you need to make the anastomosis, right?
Yeah.
So
Please, if any questions from the floor, the microphone is there. This should be an interactive session. Yes, go ahead. You can go to the microphone.
Microphone is here.
Tell us who you are and where you're from.
I'm Rajitari Silla from Sri Lanka. It's an excellent presentation. My question is, I know it's 3 inflows, but you're making an extra incision, isn't it, to how is the gastroepiploic artery. So what do you think about then the nature of minimal invasiveness is probably it's challenge when you make extra incision in the subxiphoid region.
So he's asking you, when you make the extra incision, and I want to add to his question, what kind of complications have you seen in the abdomen, gastric complications? Because a lot of the people you're addressing have zero experience with right gastrocleploid, and between you guys, we have a huge experience, and so educate us as to how safe this is.
So far, we have no SSI and no comorbidity after surgery. So you don't need to worry about this kind of things after surgery. And the reason why we don't care about another incision, because the main purpose of mixed CABG is preserving sternum. So this is very important.
You can harvest RG also endoscopic way. You can do.
And we can harvest bilateral mammary artery and GA together. So it time saving, only 1 hour to prepare all arterial graft.
Okay. One more question.
Not to belabor this too much, I'm sorry, but so you don't have issues with gastroparesis or gastric perforation or volvulus or anything like that? And I'm asking again because, like most of us here, I have no experience with this. I'm just curious.
So, sorry, I can't catch.
Any complications with gastroparesis, like distension of the stomach, or gastric complications?
Okay, no, we don't have it.
Zero.
Zero.
Okay.
No problem.
There you
But
go.
you should assess GA preoperatively using CT angiogram. It's very important.
And
to
what do you
check.
look for when you're doing the CTA?
Then we check the length and diameter of RGA. So it's very important. Sometimes you can't find out a good GA for the patient, but I think it depends on race.
Interesting.
Yeah.
Because the stomach, the blood supply to the stomach comes from 4 branches, if I remember correctly.
Yes, it is.
And when we do the Allen test in the arm, we're looking for an ulnar that works well. But in the stomach, we don't have the ability to check. We can only go by the CT angio.
It is.
So have you seen a CTA and you said no gastropaploid?
Yeah.
Because of too small?
Yeah.
Very good. Thank you very much.
Thank you.
Thank you very much.
Please.
I'm Sarah Abdulkadir from Germany. As I remember from physiology, the blood supply for stomach, it depends on the whether I am hungry or no. And I am thinking the blood flow from right epiploic, gastric epiploic, it's not prandial uphang, dependent on prandial time, or whether it has an effect when stomach empty, or that's
good question.
maybe it's a silly question. That was
Okay, basically, we do contrast CT scan with the patient, gastric empty. So you don't need to worry about this kind of thing. Yeah.
okay. That was only from physiological point of view. Thank you very much.
Thank you.
Thank you. Thank you very much.
Okay.
Good question.
Next one.
Okay, so thank you very much. Thank you. The next presentation is 3D printed anastomosis models for preoperative planning in mixed CABG. 125 patient experience identifying predictors of the procedure difficulty. Please start, Dr. Cristiano.
Good afternoon. I'm Cristiano Spadaccio, one of the cardiac surgeons at the University of Cincinnati. And today we're going to be sharing our experience with 3D printing approach as a preoperative planning tools for minimally invasive CABG. Let's say this work really originated from our attempt to address the known anatomical complexity in mid-CAB and to try and optimize preoperative planning, patient selection, and evidently try to increase the reproducibility of the procedure. And the foundation was really This work we've done in cooperation with our radiology department, where we basically segmented CT scans according to landmarks that we thought could have a surgical relevance in mid-cab, and especially the distance between the mid-sternum and the LAD in order to reach, and then the distance between the nipple and the rib cage. Also the optimal intercostal space to approach the LAD, and of course the depth of the LAD into the myocardium. And we produced 3D models that can be easily held in the hand and observed preoperatively, and really validated this approach in a small study within 12 patients, in which we show significant correlation between the 3D printing measures and the actual findings into the OR, and also a perceived high utility and time saving. So on these grounds, we went ahead and expanded a little bit this approach to 125 consecutive patients. We really aim to find anatomical and spatial thresholds that could predict surgical complexity. And beside the standard clinical outcomes, we introduced a validated subjective surgical complexity score. As you can see here, we had no mortality and 0.8% of bleeding, and we had a 3% conversion rate, which was really due to 3 lima damages and one patient in which the LAD was too deep. An additional 5% was perceived as a high demand for surgery, and in fact it really correlated with the need to elongate the lima in 3 patients, and in other 3 patients we had difficulty in reaching the chest. We went ahead and performed a multivariate adjusted regression analysis and combined it with the ROC curve so that we could find somewhat a cutoff, a numeric cutoff, to figure out what's the threshold to identify high complexity or surgical demand. And what we really found is that a distance between the mid-sternum line and the LAD above 8 centimeters or below 3 centimeters is actually associated with the high technical complexity. And similarly, when the LAD is deeper than 10 millimeters, this was also very highly correlated with high surgical demand or even conversion in this case. And as a matter of fact, you can really see from those videos that the 3D model is really able to capture very intuitively the anatomical relationship, as you can see. And this is a case in which the LAD is situated roughly 5 centimeters from the mid-sternum. But if you start to see when the LAD is much more medial, you can really understand the technical complexity, especially for reaching the coronary arteries. Whereas if you see an LAD which is very lateral, as you can see up here, you can really understand how the reach from the chest might be probably easy, but most probably the trajectory of the lima might be very long, and this in fact is actually associated with the need of elongating those conduit. This is also true when we're looking at patients that are not really so in extreme scale, but a little bit above the 8 centimeter marks, and you can really see also from this reconstruction also has the chest conformation and the position of the heart also plays a significant role. And all in all, we really found that this 3D printing model can really capture all those nuances and help in the preoperative planning. So in conclusion, and really much despite the caveat of this study, which is very much subjective as a matter of fact, but relies on quite a good number of more than 100 patients, we can really see that this 3D anatomical model is a reliable tool for preoperative planning and maybe an adjunct. And namely, when we see an LAD distance which is either above the 8 centimeter mark or the 3 centimeter mark, we know that this is going to be somewhat anticipated technical challenge. And similarly, when the LAD is very deep, then we may shy away from the procedure. Thank you very much. I'm happy to get any questions.
Cristiano, that was great. Congratulations on a very, very innovative use of current imaging technology. I think it's extremely important for people who do mid-cabs, T-cabs, and in particular posterior wall T-cab. I can see this really being able, we get a lot of films from folks and say, can you do the OM2, for example, using the T-cab approach? And we don't know until we get in. Like today's case you saw with Gianluca, the phrenic nerve was quite low. There was not a lot of posterior pericardium apparent, and it told me immediately that the heart was rotated away from us, such that the posterior wall was not going to be an easy one to get. And the LAD was also kind of maybe in that phase where it was okay. Yeah. But I can see using this to say, okay, I can look at your 3D reconstruction and tell you if we can get to that second or third OM or the posterior lateral branch. So I would propose that the second phase of your study should be to look not just at the LAD, but also at the posterior wall, because I think that's where you get the biggest bang for your buck.
That's great.
Please.
Thanks.
So that's really a great effort, and applicability. Not everybody's going to be able to build a 3D model, but there's a lot of lessons to be learned. So I have a question maybe for the panel. Well, I have two questions. One is it standard to do a CTA of the coronaries and the lima and lima-rima before all these mixed cap? Because, for example, our cardiologists, we ask them to shoot an angio of the lima for regular cap. And then the second question is, in this surgery without sternotomy, are there any contraindications to using the rima? Because when we do sternotomy, we say high A1C, COPD, et cetera, obesity. But so those are my two questions.
Thank you very much. It's a really important question. And so far, we can use bilateral mammary artery for all kind of patients, but it depends on the sternum because we harvest bilateral mammary artery under direct vision. Some can do even sternum disturb surgical field. If you use robot, we can take down bilateral mammary artery. But if I do under direct vision harvesting bilateral mammary artery, it's not easy to access to the right mammary artery. Then I abandon to use right mammary artery, but lima is okay. And sorry, one first question is yes. Definitely yes. I strongly recommend to do contrast CT scan preoperatively to assess everything. So we can decide, we can touch ascending aorta or not, or we can access right mammary artery or not, and also GE as well. So it's very important to assess everything before surgery for mixed CABG.
Okay, thank you very much.
If I may just chip in, and disclosure is that probably I have a little bit of imposter syndrome because I'm not that experienced as my friends here. But yes, we do request CT scans all the time about it, and I kind of probably introducing myself into the minimally invasive world, and especially in the robotic world. I think the only angiogram is not really able to give us the nuances of the tortuosity, the way the mammary goes, especially when you're going to be doing the harvest. And the other thing is, yes, the 3D printing model, it's definitely an adjunct, but those scans are, those models are actually printed out of a 3D rendering that can be done by basically any CT scanner with 3D capabilities. And as a matter of fact, now on, we have reduced a little bit the amount of those models because we have an office full of it, and this once you finish the operation, you don't need it anymore. Indeed, we kind of give it to the patients as a kind of memory, let's say. But at the moment, we're working with the 3D PDFs, so that basically you have it on your phone and you can kind of rotate it on the computer, and useful. You save a lot of resources because you really need to have the 3D printing lab to do it.
Okay, thank you very much, Cristiano. The next speaker comes to us all the way from Lenox Hill. Dr. Joshua Newman will talk to us about how I teach it, robotic-assisted minimally invasive direct coronary bypass. How I teach it or how I was taught it?
That was my disclaimer. You beat me to it. So thank you for having us here today. So I came a little further today. I came all the way from Bayshore. So thank you for having us. I'm Joshua Newman from Northwell Health, and I'm going to talk briefly about how we teach at the Robotic Midcap, the Nirav Patel method. So my only disclosure, as you beat me to, is that I was trained by this method. So I don't need to tell anyone in this room, but robotic coronary surgery is growing around the world, both in number of centers and in volume of operations occurring annually, which raises the question of how do we train both our current and the next generation of surgeons to be prepared for this. So our approach is we take the senior year after traditional training completes, and we focus on the robotic and the off-pump operations. You can see here we divide it into two basic skill sets, the overall skill set where we focus on the anastomotic and the sewing, and then the robotic focus. Separating this allows us to optimize OR time and have the trainee spend most of the time in the OR actually on the console and only sewing towards the end of the training. So we start out by every patient gets discussed with the trainee and the attending surgeon. Is this patient a mid-cab, a hybrid, an open operation, with reviewing history and the imaging studies? And we focus significantly on the angiograms looking at the LAD anatomy. Where is the good target? Where is our landing zone? Where should we focus on making our thoracotomy? What's the regional anatomy, et cetera, et cetera. And this is reviewed on every case. That first technical component is our OPCAB practice. So the trainee will take down a skeletonized mammary, focusing on using almost no sponge to dab any blood, using clips and electrocautery in a fashion we take robotically. And they sew the lima to the LAD. We don't open the sternal retractor more than we have to limit the space, and the assistant doesn't assist more than really blowing it most times, again, simulating that limited access incision. Paralleling that training pathway is the time that they spend in the robotic room. All trainees are expected to complete the Da Vinci simulation and then continue working on that in any free time. And then we step forward to the robotic port placement. So this, just like any other training, the attending will put the first few in, then slowly transitioning to the trainee, and then the attending won't even scrub at the beginning of the case. And I apologize, so I'm quick to save some time. So as most of you know, jumping then into the technical robotic part, this is how our standard operation, how I, after training, will take down a mammary. Training, though, is a little different. So we focus our robotic training on what is the easiest both for the trainee to learn first and what is the easiest for the attending surgeon to fix. So that starts out with distal branch division. So as you can see, the attending will open up the endothoracic fascia. We take a skeletonized mammary in a clip and Bovie fashion, and the trainee will get about 30 minutes at the beginning of the training year, starting in the mid and going distally. They get as far as they can in that 30-minute time period, and the attending will take over. After about 10 to 15 cases, what we believe gets them competency, the next step is to go distal plane development, proceeding then with proximal branch division and proximal plane development. At this point, trainee gets about 45 minutes to an hour on the console. Beginning of the year, you don't get very far. Towards the end of the year, they complete most of the operation. After that, we continue towards the remainder of what we would consider the operation. Posterior pericardiotomy creation, anterior pericardiotomy, LAD anastomotic site identification, and then mammary artery clipping, division, and then securing to the pericardium. By the time the trainee is doing this part, they'll also be sewing on the anastomosis as well. However, at the beginning of the year, most of the time spent during these robotic cases is on the console, training in the robot while they're doing the OPCAB training for anastomotic suturing. The last thing that the trainee will do is the actual sewing in the mid-cab anastomosis. This is what we feel is the most challenging to teach. It's space limiting, it's challenging to see from the assistant side, and there's no room for error. You know, as Dr. Balke mentioned this morning, the anastomosis has to be perfect. So at the beginning, the OPCAB anastomosis is the focus. Towards the end of training, they begin suturing, and then we'll just go to the other steps in this operation. But because the trainee has been sewing all year in an OPCAB setting, by the time they start sewing in this incision, the needle angles are second nature. The sewing on a moving target is second nature, and it's actually a pretty efficient situation. And they progress from anastomotic suturing to then making the actual incision, tacking up the pericardium, and so forth there. So in conclusion, deliberate practice, practice, practice. There's no magic to this. Anyone can do it. It just requires having a competency-based practice setup. We believe having a parallel situation where you sew in an OPCAB setting is extremely important. Allows the learning curve to be shortened. We think 10 to 15 cases, roughly each of those competencies is sufficient to really develop a competency with the operation, and that 1 year of additional training after completing traditional fellowship. And then this is, an image of, as you heard, as the trainee, this was my first OPCAB as an attending, having completed that program. So thank you.
Great presentation, Josh. I think this is very important, and this is the phase we're in now, is how do we train the next generation? It's been shown, we've proven it, you can do robotic coronary surgery. The question is, how do you train the next generation? My question to you is, now that you're on your own, right, you're independent
Yes, sir.
in practice, and you're doing this operation.
Yes.
And you told us that the hardest thing to master was the actual sewing of the anastomosis through a small incision, correct?
Correct. That's so the hardest to teach.
The hardest to teach. For you, which was the hardest to master?
That probably was the hardest because it's the transition from your hands are flat needle angles to everything is sewing straight down in a hole. And at least in my previous training, the robot wasn't new. I think if the robot is the first time you've sat on the robot, then that may be the more challenging part.
You answered my next question right on that, which is, so how much robotic training had you done prior to embarking on this in general surgery setting?
So none in cardiac realm. Most of my robotic training was in the thoracic on lungs, so much bulkier, much less fine movements, but comfort being on the console, how the console functions.
And my second question is, if you were to do the anastomosis robotically, do you think it would be as hard?
Having not done it, I can't say. I'm excited, though, to hopefully learn that in the near future. I think that the first few may be, but I'm hopeful that the learning curve, having now taken mammaries, will be shorter. I guess then the follow-up question is having done both, do you feel it's as hard?
Yeah, I mean, this might be controversial, but I think that doing a TCAB is immensely easier than doing a midcap, because you're looking through a small incision, and you can make it easier on yourself by making the incision bigger, but then you basically almost defeat the purpose. And so I think once we're in the phase of teaching TCAB a priori, I think we're going to realize the fact that once you have your robotic, skills up and running, continuing, because what happens when you switch from a robotic IMA takedown to a midcap is all of a sudden the memory becomes extremely small, and you're having to squint to even see it. And you were just in a position where the mammary was nice and large and everything. So I think there's a paradigm shift that's going to happen here. And once we are fully embracing TCAB, it could be a different. And this is, just food for thought and maybe even just discussion generating.
I think that's a great point. I'm not experienced in this minimally invasive stuff, but at first sight, the TCAB looks much easier. And in general surgery, like I was the department chair, we have these credentialing issues for general surgeons. They went down this road where they said, you have to be able to do a laparoscopic splenectomy before you do a robotic splenectomy. Well, that makes no sense. It's easier and safer to do the robotic one.
Right.
So, as you say, let's teach the next generation. We also have to get credentialing the proper way for the next generation, not make those mistakes but learn from the general surgery experience and grow from there.
Yeah, I agree. Awesome.
All right, thank you.
Next presentation is a prophylactic non-invasive ventilation strategy to reduce pulmonary complications after mix. Dr. Janusz Konstanty-Kalandik from Poland.
Good morning. Hello. Thank you for invitation and thank you for opportunity to present our results from our study on prophylactic non-invasive ventilation. So first question is postoperative pulmonary complication. Is it happen? How often it happened? So there was a Venice study, and it was more than 600 cases, cardiac surgery patients. And in this study, more than half of the patient has any of postoperative pulmonary complication. So still, this is a big number of patients. The most often are pleural effusion, respiratory failure, and atelectasis. The next question is it dangerous? Yes, it is. There was it increased mortality and also increase significant. There's a significant difference in mortality long-term follow-up. There was this publication based on many types of surgery, not only cardiac surgery or thoracic surgery. So let's focus on the cardiac surgery. This is more than almost 600,000 patients, and 6.7 patient has a pulmonary complication. And according to this author, the pulmonary complication increased mortality, length of stay, and increase the cost of patients. So this is about general surgery, about the many types of surgery. So what about the mid-cap? Of course, the advantage of mid-cap, I don't have to show the results in this room, but is it happen or is it a problem? In minimally invasive coronary artery bypass, probably the benefit of small incision will be observed. But even though in a huge centers like a Leipzig center, they still have a respiratory failure between 3 to 6% independently in which era, in which year they did the mid-cap. So non-invasive ventilation, when we take a look on the publication and systematic review, and if reduced postoperative pulmonary complication, this is a publication on general surgery, thoracic surgery, cardiac surgery, and so non-invasive ventilation has a opportunity, has a potential chance to improve the postoperative pulmonary complication. And this is another publication that when non-invasive ventilation significantly reduced the incidence of PBC after procedure and reduced the incidence of atelectasis. But in this publication, this meta-analysis, the cardiac surgery procedures are mainly done in cardiopulmonary bypass. So we decided to take a look of our results, and the study aims to address the existing gap of evidence by analyzing the clinical outcomes following the implementation of prophylactic non-invasive ventilation as immediate post-extubation strategy. 454 consecutive patients from 2019 to 2024, and all patients are done mid-cap. The left internal thoracic artery was harvested during the with direct vision, and it was done Lima to LA the procedure. And during the procedure, there was a single lung ventilation, and the reintubation was done immediately with the single lumen during the procedure with lung expansive visualized direct before chest closure. So we have two groups, before April 2022 and after. Why? Because in April 2022 we decided to, it is a retrospective study, but in this April 2022 we decided to use the prophylactic non-invasive ventilation in everyday practice in every patient with mid-cap. So before this time, there was formal standard of care guided postoperative pulmonary rehabilitation, and it was solely only in cases when we have to do it because of pulmonary complication. And after, we introduced 5 2-hour session of non-invasive ventilation using BIF, and there was intervention 20 to 30 minutes post-extubation, and following the initial 30-minute session of individualized respiratory therapy. And you can see there are some BPAP score results. So, what about the baseline? We have two groups, prophylactic non-invasive ventilation and historical cohort. They didn't different significantly. Even in a chronic lung disease, the numbers are not different statistically. Also, they didn't different in postoperative complication such as renal complication, re-exploration for bleeding, cardiac death, in hospital mortality. But when we take a look on the pulmonary complication, we observed that there was a significant reduction in any pulmonary complication, and also significant reduction in pneumothorax. The pneumonia and pleural puncture also was smaller in a prophylactic non-invasive ventilation. So we did the analysis, and after unadjusted analysis, we found that there's a significant reduction in odds ratio of postoperative pulmonary complication with prophylactic non-invasive ventilation. And we do this analysis. We did another deep analysis, and after controlling for the key confounders, there's also still this prophylactic non-invasive ventilation. It remained associated with the consistent significant reduction in postoperative pulmonary complication. The next thing we check how it looked like in 1 year follow-up, and in this group we observed this is superior 1 year survival in a group of patients with prophylactic non-invasive ventilation after mid-cap compared to this historical cohort. So conclusion, prophylactic non-invasive ventilation was associated with more than 50% reduction in the odds ratio of postoperative pulmonary complication after mid-cap. And we also observed 1 year survival was higher in a prophylactic non-invasive group. So we found that these findings support the incorporation of prophylactic non-invasive ventilation into enhanced recovery pathway for cardiac surgery. So in other words, we think that we use it and we think it works, and this prophylactic non-invasive ventilation can help patients. It doesn't matter if we do the mid-cap direct vision skeletonized, but still during this procedure we have to collapse for a few minutes, 3 hours left lung. So this non-invasive prophylactic non-invasive ventilation can help in reduction of postoperative pulmonary complication. Thank you.
Thank you very much. I think the discussion is going to have to happen in the hallway or during the break. We don't have time for questions, so we're going to move on to the next presentation.
Okay. So next presentation is TCAP on the DaVinci XI platform without end rate stabilizer. First 50 cases from a single center experience. So please start, Dr. Massimo.
This is from the institution that we did the TCAP from this morning. So this is the experience in 50 patients.
Thank you. Thank you. Just. Okay. So good afternoon, everyone. This is my disclosures. So basically, these are the first 50 cases through a similar technique that was shown this morning. This was the earliest experience we had, so there are slight differences. So a little bit of background. Robotically assisted mid-cap is definitely recognized worldwide as an advanced revascularization strategy for patients that are generally not suitable for traditional CABG. However, it has a main drawback, which is to be performed in a very small incision, sometimes called as a keyhole surgery. So this will definitely challenge the surgeon in the visibility and maneuverability. Totally endoscopic CABG, therefore, can overcome all of these limitations. However, the stabilizer for the most common device that is utilized has been withdrawn, and so we tried to overcome this problem, combining the technology of the Gel Point Mini, the AirSeal, and the Octopus Noodle. And you probably have seen this in today's live case. So I will go very quickly. You've seen this this morning. A series of dilators. Then you put, you put the Alexis inside. Very difficult, sorry. Okay. And then you put all the combination of the technologies inside the subxiphoid incision. So this was the original conformation, all the anatomical landmarks. You have the 3 ports, 2nd, 4th, and 6th, the working port in the paracostal area, and the one in the subxiphoid, and this was during the final combination. You now seen in the live case today, we also have the nano system for camera and the fourth robotic arm in the subxiphoid region. And then after this, the anastomosis is performed. It's very similar to the one you've seen this morning. So we've included all patients undergoing TCAP in our center between January 24 and June 25. Of course, we started with low risk, favorable anatomy, and then progressively increased difficulty, including now CTOs. If needed, concomitant robotic left atrial appendage occlusion was also performed. So these are the first 51 cases performed, quite young patients, 62 years, mostly men, high BMI. You can see all the preoperative characteristics on the table on your left. Focusing on the outcomes, intraoperative and postoperative, you can see how there were no conversions to sternotomy, excellent flows. 40% were part of a hybrid management, and more than 60% were extubated in the OR. Very fearful complications like stroke and bleeding were minimal. Atrial fibrillation was very low. And looking at discharge, the median discharge length of stay was 2 days. Almost 80% were discharged within 2 days, and all except one were discharged home. No mortality at 30 days. Of course, follow-up very short for now, but till now we haven't seen mortality, strokes, MI, or repeat revascularization at follow-up. So despite robotically assisted mid-cap has paved the way for minimally invasive CABG, and it's still a valid technique, it has some important drawbacks which can be overcome by TCAP. We have shown through our study that postoperative AF was very low, and also hospital length of stay very low. We could compare it like a surgical PCI. And we hypothesize that this short length of stay is due to the reduced postoperative pain, so the reduced use of analgesic medication and earlier mobilization. Thank you for your attention.
We have time for 1 or 2 questions. Anybody from the floor? Or
It is for Lima to LAD anastomosis?
Yes, these are, the early cases were all Lima to LAD. Now we have started doing also sequential with diagonal, and we did 2 cases right coronary artery.
Oh, good. Thank you.
But these are like done a few weeks ago, a few months ago. They're not inside these 50 cases.
Matteo.
Matteo Pettinari from Massimo. Very nice presentation and terrific work. Just a question very quick. Which is the percentage now of patients that are going for TCAP and mid-cap, and which are the selection criteria when you say, okay, this patient I really prefer to do a mid-cap, or which one is for a TCAP?
So I cannot, of course, cannot speak for the person who is doing it. At the beginning, there were all robotically assisted mid-caps. I think now, I cannot speak for him, but I think now he starts by saying, can I do TCAP? And he has to, of course, evaluate with heart team discussion, anatomy, the location of the LAD, and he then decides how to proceed.
One more question. What the contraindication of TCAP for single bypass?
Well, this is a very tough question. This is a very tough question because as we are trying, Dr. Torregrossa is trying to show is that all the different type of surgery, starting from sternotomy to TCAP, they should not be comparing each other. You should choose the right procedure for the right patient. So I think it's difficult to have a general rule to exclude patients. You should individually evaluate the patients.
Okay. Very good.
Okay.
Thank you very much. Okay. The next paper comes to us all the way from Belgium, from Leuven, from Wouter Oosterling's group. Dr. Dimitri Denisyuk will be talking about, Dr. Xander Jacquemin will be talking about midterm outcomes of bilateral versus single IMA grafting in minimally invasive coronary bypass midcap. And this is a center with a very large experience in robotic midcap and bilateral ITA use.
Thank you so much for the introduction. I'm here on behalf of Professor Oosterling to present our midterm outcomes of BIMA versus CIMA in midcap, and we performed a propensity matched analysis. So as you all know, CABG is the cornerstone for multivessel coronary disease with Lima LAD as a gold standard, and it has been proposed that total arterial revascularization using BIMA offers superior long-term outcomes in conventional CABG. Minimally invasive techniques are on the rise: midcap, robotic-assisted midcap, TCAP, as the previous colleague presented. Hybrid coronary revascularizations are increasingly used. There is an evidence gap, however. Few direct comparisons in BIMA versus CIMA in minimally invasive in midcap. So we performed a single-center retrospective cohort study between 2015 and 2023 of all consecutive robotic-assisted midcap cases performed by a single operating surgeon. And we looked at outcomes such as mortality, MACE, stroke, myocardial infarction, target vessel revascularization, and we compared 659 patients in total, of which 577 had a CIMA and 82 had a bilateral IMA. We performed 1-to-4 propensity score matching and matched 298 patients to 77 in the BIMA group with comparable baseline characteristics. Then we also performed an exploratory subgroup analysis in patients who underwent hybrid coronary revascularization, and we had 178 patients in the CIMA group compared to only 22 in the bilateral IMA group. So this is the baseline characteristics table you can see here. On the left, you can see before matching compared to on the right after matching. And the main thing I want to highlight in this table is that actually there's practically no differences between our patient selection in CIMA versus BIMA before matching or obviously after matching. When we look at perioperative outcomes, the only thing that was significantly different between the groups was, of course, surgery time. This persisted even after matching, as you can see, 210 minutes compared to 349 in the BIMA group. Another thing that we found was that after matching, patients stayed on average a day longer in the hospital when they received BIMA. However, 30-day mortality or 30-day MACE was low in both groups with 1% or 0% respectively. When we look at the midterm outcomes over 4 years, you can look here in the unadjusted population. So this is our entire experience. There is no significant differences between the groups in mortality, in MACE, stroke, or myocardial infarction, and also not in target vessel revascularization, which I couldn't put on this figure here. Then when we look at the propensity score matched analysis, we found similar results. No significant differences between the groups. However, the confidence intervals are very wide. If you look at the mortality rates, the hazard ratio is 0.37 with very wide confidence intervals from 0.05 to 2.84 over the 4-year time period. Similar results were obtained with no significant differences in MACE, stroke, or myocardial infarction and target vessel revascularization. Then when we looked at the exploratory analysis of the only patients undergoing hybrid coronary revascularization, we found similar findings that there's no differences in mortality or MACE over a 3-year time period because we had less sample size to say something. Similar results were in the propensity score matched cohorts with no significant differences. But as you all know, this is exploratory with low sample size, so it's very hard to draw conclusions from this data. So as with all observational studies, there are some limitations I want to discuss. It's retrospective, single center. We only have a modest BIMA sample size. We don't use the radial artery, and these findings are midterm, so we cannot say if BIMA is going to be better on the long term. And this may not generalize to early stage robotic programs, as we have shown that there's a substantial learning curve as to what a previous colleague also presented. So in conclusion, our work shows that BIMA in robotic-assisted mid-cap is feasible and safe for the first 4 years. There's no increase in early or mid-term MACE or mortality. However, we need long-term multi-center data to really show a benefit of BIMA. Thank you all. I'll take any questions.
Thank you very much. Well, what's your criteria for choosing bilateral or single IMA in daily practice? For example, age of patients or coronary anatomy?
So every patient is a multidisciplinary approach, which is discussed in the heart team. So obviously my senior author, Professor Oosterling, decides if he thinks it's feasible to do it, then he will do it for all patients. He really tries to be as broad as possible, and he tries to give everyone a BIMA. But as to his specific cutoff criteria,
Feasible, I mean habitus, body habitus, or thoracic anatomy?
He looks at thoracic anatomy and body habitus, but I wouldn't say it is such a major limitation. We do have some patients who have larger BMI, but most patients have lower BMIs.
Okay. Questions from the floor? Okay, thank you very much.
Sorry, just a moment.
Next speaker comes from Russia, Dr. Dmitry Denisyuk. He will present off-pump multi-vessel mixed grafting via left-sided mini-thoracotomy in patients with severe and extreme obesity. Please.
Dear colleagues, RT study aims to evaluate in hospital outcomes following mixed CABG in patients with obesity. Severe obesity significantly increases the risk of complication following full sternotomy and coronary artery bypass grafting. This systematic review demonstrated highlights sternal wound complication in patients with diabetes and obesity. The treatment and reconstruction of sternal infection and long, difficult, and expensive. Mixed cap via left side mini-thoracotomy is a minimal invasive surgical approach in the treatment for coronary artery disease. Multi-invasive mixed CABG is widely discussed nowadays, but we don't have quite enough data how safe and effective mid-caps in the compared to the full sternotomy approach in patients with obesity. This slide demonstrates some surgical challenge, potential benefits of mixed cap for obesity patient, faster recovery and reduced risk of sternal infection. You can see very bad cosmetic results after CABG and via full sternotomy, and we can see good cosmetic result after mixed CABG. In our opinion, preoperative anatomical imaging is very important as for increasing the chance of successful in mid-CABG in patients with obesity. Specifically, utilization of preoperative CT scan is critical in order to avoid complication, avoid conversion, achieve best results. Short video mixed cap in patient with safe obesity. You can see coronary angiogram. Horace Lima. Horace Safina. So, I would like to present our experience. We investigate 129 patient with disability underweight off-pump multivessel mid-cap via left main thoracotomy. Our results, all patients had elective indication for hospitalization. The mean graft number 2.3. Lima LED anastomosis was performed 99% in patient. We did not have conversion in full sternotomy. Number of grafts dipping on the target vessel. In all cases, we used transit time follow-up management of intraoperative graft potency control. More than 17% of patients underwent multi-arterial mixed cap. 7% patient underwent total arterial mixed cap. This slide presents clinical outcomes. Rate of reoperation for bleeding, transfusions were low. 9 patients need non-invasive postoperative pressure ventilation for respiratory flowering. 4 patients had flowering and indicate of atrial fibrillation was 90%. 30% patient had pleural complication. There case deep wound infection. Main hospital of stay was 7.1 plus or minus 1.4 days. 11 patients had hybrid revascularization. No case in hospital death. To sum it up, off-pump multivessel minimally invasive coronary artery bypass grafting from left side main thoracotomy can be performed safe and effective and in patients with severe and extreme obesity, providing a minimally invasive option for complete coronary revascularization is a case of multivessel disease. Preoperative CT scan allow to optimize surgical step. This approach eliminates 4 complication association to the sternotomy, making it a surgical alternative for patients with obesity. Thank you for your attention.
Thank you very much. I don't think we have time for questions. That was a very excellent presentation, and I think we've all experienced the same in the obese patient. Avoiding the sternotomy is very, very valuable. So we're just going to have to move on. Thank you very much. No time for questions. Dr. Baudo, Massimo is up for 2 presentations on propensity-matched studies comparing mid-cab to T-cab, which he said we shouldn't be doing, but nevertheless we are. And then another one comparing flow between robotic coronary bypass and sternotomy. Massimo.
Thank you. Thank you again. So, as kindly introduced, we will be comparing total endoscopic and robotic assisted. These are my disclosures. So basically the same introduction as before. Robotic assisted mid-cab is recognized as an advanced revascularization strategy. Limitation is the incision keyhole surgery. In fact, T-cab can provide higher precision, dexterity, visualization to the surgeon. So we will be comparing these 2 groups in a balanced population and look also at hospital costs. Balancing was performed through entropy balancing, and compared to propensity scores, it uses a mathematical reweighing technique which aligns all distribution of covariates without losing any patients. So you will see the tables that will show sum of weights, and they may be like half patients or fraction of patients. It's just a matter of weighting. These are the preoperative characteristics. I know it's a very busy slides. This is just to show you that between the two groups, the weighting was making the two groups more balanced as possible. We can summarize all of this data with this love plot showing pre-balancing and after balancing. You can see how the balancing has well balanced the two groups. Now, looking at the postoperative outcomes, there were basically no postoperative, intraoperative complications. Also, the most fearful ones, strokes, bleeding, were minimal. The only differences that we could note is the difference in the length of stay, as shown previously, 2 days for the TCAP and 30-day readmission rates. Looking at the hospital cost instead, TCAP was indeed associated with higher cost, all the surgical one except the surgical times, which was comparable between the two. However, the shorter hospital stay in the TCAP group reduced all the other managing costs, so nursing, laboratory, pharmacology, and so on. As a result, the total direct, indirect, and total overall costs were lower for the TCAP group. So, in conclusion, despite both techniques are absolutely valid, we showed in our study how, despite the lower experience with TCAP, it's a more earlier technique in our center, the operative time was similar. TCAP had 33% shorter hospital stay, and this basically resulted in lower hospital costs, despite TCAP, considering it performs the whole procedure robotically, is associated with higher surgical costs. Thank you for your attention.
Thank you for leaving us time to discuss. I have a question. Did you look at why the costs of TCAP were higher? Was it because of the various, because you're using a stabilizer in both cases.
Yes.
You're using a stitch, you're using various things. Why was the TCAP more expensive intraoperatively?
So we got all the financial information by the finance guy. Basically, if I can show you the table, the surgical timing, which is basically considering the cost of having the procedure going on, those were similar. The higher costs were in the implanting devices, and in the sorry, you can see the mic, and in the sorry here, and in the category which is called surgical other, which also includes the anesthesiology timing.
Interesting. Please.
Very short question for Massimo. Great work. You showed us that the robotic-assisted population discharges after 2 days. I presume you have a different path on the postoperative follow-up of these patients, so they come every day at the outpatient clinic, or how do you follow them?
So basically, as I was trying to highlight in the previous abstract, the management technically is the same. The fact that probably differs is that performing everything endoscopically without the surgical incision, that despite being very small, the postoperative pain is reduced. It reduces the amount of analgesics, painkillers that you have to give to the patient, and this generally favors earlier mobility to the patient. It's not the proper term, but we could consider it like an enhanced recovery after surgery, ERAS. protocol just because you are reducing the surgical impact to the patient itself.
You're using the cryo.
Always, but those for both.
For both, yeah.
So that is the same for both. It's not a determining factor between the two.
Right. Excellent. Do you want to go ahead to your next
one?
abstract?
Yes, sure.
Might as well.
So if in the previous abstract we have compared the two robotic approaches, we are now comparing the robotic approach in general to sternotomy in general, CABG, with a particular focus on transit time flow measurements. So same disclosures. So again, robotic-assisted CABG and sternotomy CABG are excellent revascularization strategy. However, they have critical technical differences. Over the last 20 years, robotic CABG has evolved, optimized all outcomes. However, the adoption remains very limited, and there are various reasons why this happens. It can be costs, the training that is required, and the high technical demand of the procedure itself. So in this study, we are comparing the robotic and the sternotomy with particular focus on TTFM through a balanced through propensity score matching. So we retrospectively enrolled all our robotically and sternotomy coronary patients from July 21 to April 25. We only considered strict LITA LAD anastomosis, so all sequentials, composite grafts were excluded to have the most fairest comparison between the two groups. The two groups were balanced with 1-to-1 propensity score matching, and regarding TTFM data, the Medistim Case Cloud data system was used, which I personally found excellent to retrieve and gather all the MiraQ data in one single place and retrieve the data. So once again, I have a very busy table for unmatched and matched population. Again, this is just to show how of course, considering the limitation of the methodology, the two groups were balanced. And once again, we can summarize everything in this love plot showing how the two groups were balanced. Looking at the postoperative, intraoperative, first the intraoperative outcomes, despite propensity score matching, the technical differences between the two groups were still evident. Robotic approach had more hybrid procedures, and despite sternotomy had a very high percent of off-pump surgery, there were indeed other types of revascularization on pump or beating heart surgery. Looking at the TTFM data, both in the unmatched and matched population, there was no difference in the flow and the diastolic filling. However, we showed a significant difference in PI and in the backflow. Note, despite there were significant differences, however, all the values were within the acceptance rate of TTFM data. Looking at postoperative data, of course, robotic was still associated with higher rates of OR extubation, shorter ICU and hospital length of stay, and the lower transfusion rates compared to the sternotomy cases. So, in conclusion, despite both approaches are excellent for revascularization strategies, procedural differences could not be overcome by matching. Robotic approach was associated with shorter ICU and hospital length of stay, lower rates of blood transfusion, probably due to the less invasiveness of the procedure. Regarding TTFM data, we noticed that the PI and the backflow were significantly lower in the sternotomy cases. We don't have an exact explanation why. Our hypothesis is that for robotic cases, the probes were probably suboptimal, and for robotic cases, the stabilizer is still always in place on the heart, which may contribute to the slightly lower, worse outcomes compared to sternotomy. Thank you again for your attention.
Thank you, Massimo. Great study. Any questions from the floor? Why did you think that there might be a difference between the robotic cases and the sternotomy cases in the flow? What was the hypothesis that would have created?
So no, the mean graft flow was identical. It was the PI and the backflow.
The backflow. No, I'm asking why the study from the start. Like, why would you have thought that there would be a difference?
Well, I think our hypothesis was that the environment where the anastomosis was taken care. In sternotomy, you have basically an open chest, while in robotic approaches, depending on TCAB or robotic assisted, you still have a very closed chest, so with CO2 insufflation, so which may impact the maybe we were investigating the flow or in general TTFM parameters, and we were also thinking about maybe the stabilizer, how it is performance of the stabilizer in impacting the reading and the flow during measurement.
Last question.
It's an excellent presentation. I would like to know what's the duration of anastomosis on sternotomy and the robotic.
Sorry, can you repeat the question?
No, my question is what's the duration of anastomosis? How long it will take to do the robotic assisted anastomosis and the sternotomy with the sternotomy?
Now basically the surgeon was Dr. Torregrossa. He now has basically the same amount of time between the two approaches. There is basically for a normal anastomosis is 16-17 minutes per anastomosis. It isn't influenced by the approach. Thank you.
Next presentation coming from Professor Balki's group, graft configuration in over thousands TCAPs matching ITA conduits to targets. Please.
Thank you. Okay. Thank you. It's an honor to present here today on behalf of Dr. Balki and his team. I'll be discussing graft configurations in over 1,000 TCABs. Here are disclosures. Robotic beating heart TCAB can use single or bilateral ITAs, as you've heard today. And given the sternal sparing and closed chest nature of the approach, you can graft a variety of targets, including the LAD as well as non-LAD targets. And so we sought to study our total graft configurations in over 1,000 TCABs to date. We've widely published on Dr. Balki's TCAB experience. So prior at AETS, we've looked at our 10-year outcomes of our whole TCAB series, including both single and multi-vessel. We have looked at 10-year outcomes of bilateral ITA grafting in this population. We've looked specifically at some configurations of grafting. For example, we've compared left and right ITA grafting to the LAD. We've looked at grafting posterior wall targets, including at ICC, and this was in 2022 in Tokyo. And most recently, we presented at EX, and we discussed whether cardiopulmonary bypass was necessary for grafting these posterior wall targets. But we've never looked at all graft configurations in over 1,000 TCABs to date, which is what we aim to do in this study. So you can see the video playing here of our operative approach. So again, this is a retrospective review, a single center between July of 2013 and October of this year. We looked at intraoperative outcomes, we looked at perioperative outcomes, as well as graft patency in patients undergoing hybrid. We use the Da Vinci SI robot. All cases are performed on a beating heart without cardiopulmonary bypass, with the use of the end-over stabilizer, as you can see here. We skeletonized ITAs and use intraluminal papaverin, as you saw. And at the current moment, we do a running suture technique with a double-arm 7-0 Pronova. And then at the end, as you saw, we check flow on all anastomoses. Looking at results, the demographics are pretty standard. We've published widely on this. The mean STS score in this group was 1.45%. 54% of patients underwent multi-vessel TCAB, of which 86% received betas. There was 15 patients that required CPB. There was a single conversion to sternotomy in this cohort, and 42% of patients were intent to treat hybrid revascularization. Looking specifically at the grafts, of which there was a total of over 1,600 grafts. The majority of them were in situ grafts. So looking at the non-in situ, there was 113 sequential grafts. You can see the breakdown of LITA and RITA there. And there were only actually 48 Y grafts, which we were somewhat surprised to see. And here's the distribution or the configurations of the Y grafts here, including 3 natural Ys. There was 1.62 grafts per patient. The majority of grafts were with a suture technique, which, as I mentioned, is the only method used now. That was in 62%, or 999 grafts, and 36% were constructed with the Flex-A anastomotic device, which we previously used but no longer do. And looking at specifically the LITA grafts, of which there were over 1,000, not surprisingly, the majority went to the LAD, 70%. 15% went to circumflex, 13% to the diag or ramus, and just 2% to RCA branches. And this is the mean flow and PI for the LITA grafts here. On the other hand, looking at RITA grafts, of which there were 532 total, it was pretty evenly split between the circumflex and LAD, 37 and 34% respectively, 23% to diag or ramus, and 6% to RCA branches. The majority of these were actually isolated RIMA to RCA using a right-sided port placement approach. And the mean RIMA flow and PI are here. Post-op, also pretty standard data that we've previously published on. The mean hospital length of stay is just over 2 days in this cohort. The mortality O to E ratio is 0.48. 11% new post-operative atrial fibrillation. 8 patients required take back for bleeding. Midterm follow-up, notably this is 100% complete in over 1,000 patients with a mean follow-up of 4.5 years and the longest follow-up now being 12 years. Cardiac mortality is 2.1%. 12 patients required repeat cardiac surgery. 85 patients required PCI outside of hybrid, and 2.2% were in culprit vessels. There were 332 patients that were that completed their hybrid revascularization, and of this group, 442 total grafts imaged. So the overall patency is 97% in this group. The overall RIMA patency is 96%, and LIMA patency 98%. In conclusion, in robotic beating heart TCAB, a wide range of graft configurations can be performed with excellent early patency and clinical outcomes. Of course, further studies are needed, and several limitations to the study that are noted here. Happy to take any questions. Thank you.
Any question from the, okay.
Terrific presentation and terrific results from SAM group. I saw that there was a not so high percentage of Y graft. When was your choice to use for Y graft? And then I will go for a second question.
Of course. So I think the question that I had to ask Dr. Balke before giving this presentation was what's the grafting strategy? And we have previously discussed our grafting strategy in terms of target and conduit. So we use only IMAs in TCAB, or in Dr. Balke's practice, and we aim to keep the LIMA to LAD configuration, but in giving this presentation, I learned and he aims to keep the grafts in situ, or the conduits in situ. And so that is the goal majority of the time. And so I think when you're doing, if you want to say, there were 75 3-vessel TCABs and 3 quadruple vessel TCABs. So those are the cases that I think you see sequential and Ys, and I would defer to him on the nuances of choosing between Y and sequential and TCAB and the tips and tricks there.
So some bailout case when you have some problem on the RIMA and you
I think one notable thing is that the chest is closed, so the RIMA can reach. And so most commonly the LIMA goes to the LAD and RIMA can go to a lateral wall target. But if the RIMA does not reach, the heart is big or whatever it may, the target's farther, we will put RIMA to LAD and it reaches the LAD always just fine because the sternum is together. And then we'll put LIMA to the lateral wall target.
Yeah, pretty much similar to what Sarah summarized. Nice presentation, Sarah. Excellent job. I think what Keita said initially is that he prefers to have 3 inflows. When asked why use a gastroepiploic, you want that separate inflow. And so as opposed to having everything based off the LITA, and I know that's a very doable procedure and very well validated, we take the advantage of the fact that the sternum is intact and the RITA will reach many different places that it wouldn't reach otherwise if the sternum was open. And so our only indication to actually take the LITA out of its natural inflow and put it on the LITA, say for example, or take a distal third of a LITA and put it onto the proximal LITA for a LITA Y or a lambda, is when we can't really reach what we want to reach with the in situ. And so it's not common. So you saw it's very rare. I was actually surprised by the number that was less than what we thought it was going to be.
And the second question is a concern that I also, when you have a large mediary branch that is 3 millimeter to use 3 millimeter, and its graft sometimes is worrying in terms of flow, for competition of flow.
Yes.
When you have this kind of intermediary vessel that often are also intramural, what you suggest in situ?
I totally agree. Yeah, I think taking a Y is maybe a little bit less disturbing, and especially when you don't want to do a sequential and you're worried about the proximal one stealing flow from the distal. I think a Y graft works well. Many of our Ys were taking, if you can see here, I think it was 14 grafts that were the distal end of the LITA off of the LITA itself, so saving the RITA for its own thing. It's something that you do, I know. I've seen you say that.
Yeah, really.
Okay. Any question? Okay, thank you very much. So next is the internal thoracic artery grafting, experiencing to arteriovenous fistula in hemodialysis patient undergoing robotic TCAB early and midterm outcome. So please start here.
Good afternoon, and thank you for the opportunity to present. My name is Ria Basine, and I'll be discussing outcomes of hemodialysis patients who underwent robotic totally endoscopic coronary artery bypass with internal thoracic artery grafting ipsilateral to their arteriovenous fistula. These are my disclosures. In hemodialysis patients with upper extremity AV fistula, using an ipsilateral ITA may risk coronary steal and compromise myocardial perfusion. In TCAB, majority of conduits are ITA grafts. Therefore, we have the question of using optimal graft choice and having a great strategy for these patients with an AV fistula. We looked at TCAB patients at our institution with end-stage renal disease on hemodialysis via an upper extremity AV fistula and evaluated the early, midterm, and angiographic outcomes. Midterm data was collected through annual phone call follow-up, and angiographic data was available for patients who underwent staged PCI after TCAB. Between July 2013 and June 2025, 972 patients underwent robotic beating heart TCAB, of which 34 were dialysis patients. Of these, 10 were excluded from laterality analysis as they did not have upper extremity AV fistula access. Among the remaining 24 patients, ITA grafts were used ipsilateral to the AV fistula in 18 patients who are the focus of this review. All procedures were performed using the Da Vinci SI robot with full skeletonization of the ITA conduits and the use of mostly in situ grafts to the LAD and left circumflex. As you can see from the demographic results, this was a very high-risk group, 61% insulin dependent, and mean STS risk was 5.5. There were 17 left-sided AV fistulas and 1 on the right. Majority were single vessel TCABs, 39% were double vessel, and 1 patient had a triple vessel TCAB. 1 patient received a sequential graft with LITA, and 1 received a Y graft with RITA. There was 0 30-day mortality in this high-risk group. There were a total of 27 grafts with distribution as seen here, and in 18 patients with ipsilateral grafts, there were a total of 19 targets, as we can see. Majority of the LITA were grafted to the LAD, and the same goes for the single RITA. The average flow of the ipsilateral hemodialysis grafts was 82, and that is comparable to the average flow in our overall TCAP cohort, which is 88. There were 11 completed hybrids, which gave us 9 postoperative angiograms. 10 ipsilateral grafts were available for review, and of these, 1 graft failed. Of the total grafts, there were 14 grafts in which the graft patency was 93%. This is the single patient who had the failed graft around 2 months postoperatively. As you can see, the quality of the LITA is poor and inflammatory, and operative findings had noted that the LITA was tortuous with surrounding inflammatory changes. The target vessel, which is the LAD in this case, is diffusely calcified, and the flow was noted to be 75. In contrast, we have the 5-week postoperative angiogram for the patient who received a sequential graft with LITA to the distal LAD and diagonal. During surgery, flow was measured to be 340, and in these videos, you can see the excellent flow from the conduit. The operative findings in postoperative angiography for these patients suggest that the quality of both the conduit and the target may be the attributing factor to the poor graft outcome that we saw in that first patient rather than subclavian steel. Midterm follow-up was complete in 100% of patients at a mean of 34 months. As I mentioned, at 30 days, there was 0 mortality and 0 MACE. At 1 year, there was no cardiac mortality and 89% freedom from MACE. And at 3 years, there was 1 cardiac mortality and 78% freedom from MACE. Only one of the ipsilateral ITA grafts required repeat revascularization via PCI. In the small series of hemodialysis patients undergoing robotic TCAP, there was only 1 string sign in the 10 grafts that were imaged. We did not change our grafting strategy, and these patients had acceptable perioperative outcomes. Therefore, it is reasonable to use ITA grafts ipsilateral to upper extremity AV fistulas, and our findings provide no strong evidence to defer this use, but larger studies are warranted. Thank you.
Any question from Ron, please?
Nice presentation, fantastic data. This may be quite very difficult data to retrieve, but do you know the position on the arm of the fistula, if it was at the forearm or the arm? Because the literature shows that different position may influence differently the stealing phenomenon.
Yes, thank you for your question. These were all upper extremity AV fistulas that we looked at for these specific 18 patients.
I knew somebody was going to ask that question. No, the answer is we don't, but that's very good. And what we should have done was probably figure out if they were, so he's asking were they in the forearm or were they in the upper arm? And that may make a difference in terms of the veracity of the flow in the graft, but that is a good question and that we don't have the answer to.
Thank you very much.
Something to look for.
Do you have any contraindication to use the ITA, the same side AV fistula?
Well, that was the reason for to looking into it to see if on the ones that we'd used the same side, was there a difference in angiographic patency or in the flows, and we didn't see any differences in flows. And we sometimes shy away from using the ipsilateral. Generally speaking, if we're going to go to one target, I think we're okay. I don't know what people's experience is in open cases, whether or not one would use it. I think the thing not to do is to use it as your sole inflow for all the targets if you have an ipsilateral AV fistula. But
exactly. Okay. Thank you very much.
Thank you.
So let's see here. Our next presentation is going to be from Sri Lanka. No, not from Sri Lanka. Yes, he's here. 11 years of minimal invasive, multi-center retrospective cohort study of mid-cab by a single surgeon in Sri Lanka, Dr. De Silva.
Good afternoon, distinguished faculty, my friends and colleagues. I'm actually honored to present my the largest Sri Lankan surgeon's experience in minimal invasive cardiac surgery, direct coronary artery bypass graft surgery, over last 11 years on 4 cardiac centers in Colombo. And I bring, is it, oh sorry, you had launched it, right? Sorry about this. Yeah.
Click that, yeah.
No, it's not.
No, left. Just click. There you go.
Okay. Yeah. So I'll be presenting on the 11 years of minimal invasion, a multi-center retrospective cohort study of minimal invasive direct coronary artery bypass graft surgery by a single Sri Lankan surgeon in Sri Lanka. At the same time, I bring greetings from Sri Lanka. How do you go to the next one? Sorry. I bring greetings from Sri Lanka, one of the most beautiful islands in the world, and it's supposed to be the pearl of Indian Ocean. And there are 20 million of people and served by 20 cardiac surgeons. And so our objective was to evaluate perioperative outcome and procedural safety in high volume resource limited settings. So methodology was, we did conduct a retrospective descriptive cohort study in 610 patients from 2014 to 2025 April across 4 cardiac centers in Colombo. Data was extracted from bedhead ticket by using SPSS-V28, and we look into the patient demographics, comorbidities, operative details, and post-operative outcome. And the patient profile was, mean age was 57.5 years. The majority was male, 72%, and the mostly comorbidities were hypertension in 45.7%, and diabetes mellitus was 45.6%, and LV function was preserved in 73% of patients, making it more enabled for the minimally invasive cardiac surgery. The operative details. Single vessel mid-cap was done in 70.9% of patients, multi-vessel mid-cap in 25.9% patients, and hybrid was in 3.3% of patients. So out of the patient who has had surgical total revascularization, 73.5% patient had lima to LAD, and 19.5% patient received 2 grafts, and 5.3% patient received 3 grafts, and 1.4% patient received 4 grafts. And the key outcome was mean operative time was 152 minutes, and median ICU stay about 3 days, and median hours of ventilatory support was 8 hours. And in-hospital mortality was 0.48%, which is less than predicted Euroscope about 0.7%. And intraoperative transfusion was 2.2%, and postoperative transfusion was 20.7%, which remained low. And when the postoperative complications are concerned, cardiac arrest and 0.9% of patients, re-exploration due to the tamponade was 1.4% of patients, arrhythmias was 4.4% of patients, mainly atrial fibrillation in 3.6% of patients. And out of the respiratory complications, pleural effusion was in 2.2% of patients, pneumothorax 0.6%, and pneumonia 0.8%. And acute renal failure in 2.8% of patients, and out of them 0.6% received dialysis. Surgical site infection was 0.8% of patients. However, notably there was documented 30% of sepsis. I think it may be due to the different centers, the way they have defined the sepsis and the documentation issues. However, we concluded this series demonstrated the mid-cap can be performed safely and effectively even in resource-limited environments, provided techniques and perioperative support are consistent. And these results strongly support broader regional adoption of minimal invasive coronary surgery. Thank you very much. So I'm pleased to take any questions, and I'm honored to present my paper in Dr. Bolke and Dr. Kitas and the Thank you.
Thank you very much. Any questions for Dr. De Silva from the floor? Excellent results on 11 years. Thank you very much.
Congratulations. So next presentation is extracorporeal RIMA radial artery eye graft for aortic off-bone total arterial CABG by minimally invasive access. Please start, Dr. Westbaum.
From Santa Barbara.
No, just a quick comment. I'm not from Santa Barbara. I'm from Ecuador. They made a mistake there. So how can I see my... This is me. That's it. Okay.
You want to sit over?
So I'm going to talk about extracorporeal RIMA radial extension. So nothing to declare. So we do the same incision, the mini thoracotomy. We do the harvest of the vessels. We do right mammary first. Then we do left mammary. We use harmonic energy. We usually do it under direct vision, but for teaching purposes, we do it on video. So we start, we do a skin incision to put a 10 millimeter trocar in the second intercostal space. Then we grab from the inside the RIMA and we take it out. So that's a RIMA. We're taking it out through the second intercostal space. Same here. We click, cut, and we grab it and we take it out of the body. For the main purpose of doing the anastomosis outside of the body, it will be super comfortable and straightforward. That's a flow of the RIMA. That's pulsating. And that's the radial and the RIMA. The assistant will hold it with a non-dominant hand or dominant hand, and you can suture like you do in training. Super straightforward at the level of your belly. No problem at all to do an eye extension with an 8/0 running proline. We tie it and we test. So you see a big conduit that can reach all the left side targets. You can do sequential, you can do Y, maybe Y, T, whatever you want to do. And then from inside the body, we pull back the conduit. It does seem a little bit harsh, but it is not that hard. It's very easy to pull it down. Same here. Pull it down. And that's the length of the conduit. You can reach anything you want. That's inside of the body. You can even put in the femoral if you want. It's very big. Flows amazing. See another patient, very good flow. And you can do a Y graft to do two marginals. That's the length. Once again, the length. And we're preparing the site. So when we're doing, we do take the pericardium stitches, not in the skin, but outside of in another skin stab incision. And that's a presentation. That's how we see a marginal branch. That's another exposure of the vessel. That's another marginal exposure. So you see, you do have very good control, and you do have good exposure to treat the lateral wall vessels. Another. So anastomosis, they're not that tough if you have a good presentation. There are some tricks, but you can do the radial, the RIMA radial extension to treat all the left-sided vessels, and you will be very comfortable almost all the time, because some days you will suffer, but almost all the times to do anastomosis in the left-sided vessels. The exposure of a second marginal, a lower one. We don't use it for the PDA. The PDA, we use a gastroeploic artery. But for first marginal, for second marginal, or for ramus, it's perfect. That's it. Final view of a patient. And this is why we do this. 81 years old, first day of post-op, 2 memories. So he's dancing, shaking it a little bit, and that's it. Thank you very much. I'm happy to take questions.
Any question from the floor?
I have a comment. So Dr. Kita gave me a good advice. You can use a trocar. I do like the trocar. I believe in the trocar, but you can use an XX Alexis retractor. You can put it in the same way as we've seen Gianluca does it in the second intercostal space. We don't have it available, so we use a 10 millimeter trocar. At the beginning, we use a 5 millimeter, but when we pulled down the conduit, it was a little bit hard. You felt a little resistance. With a 10 millimeter trocar, you will have a bigger space in the muscle, so you can pull back the conduit without any resistance.
10 millimeter is the key. Right?
Yeah, 10 millimeter the key, or the XX that Keita told me.
Okay.
Very good. Thank you very much.
Thank you very much.
I think, we should wrap up soon. Our final speaker is Dr. Vadim Popov, my good friend, who's going to tell us about 15 years of experience in performing mid-cap procedures.
Good afternoon, dear Chairman, dear colleagues. I have no disclosures. So mid-cap is a potential alternative for traditional CABG, not only for patients with isolated LAD, but also for those with multi-vessel disease. Mid-cap procedure in single-vessel LAD are associated with very low in-hospital morbidity and mortality, and it did not change despite worsening clinical profiles. Most studies comparing RCR with standard CABG in multi-vessel disease have demonstrated comparable results. We are performing mid-cap since 2011, since 2017 with thoracoscopic assistance. In a retrospective study of 514 patients with isolated LAD lesion, we compared the standard mid-cap and mid-cap with thoracoscopic assistance. Clinical characteristics has no differences. There were no deaths, MACE, repeat revascularization. The average in-hospital stay was 7 days. Blood loss was low. In hospital results, operation time in the second group was shorter and the complication rate was lower. There were 8 conversions to sternotomy in the first group and 4 in the second group. The mortality and MACE rate were not statistically significant in 12 months follow-up. Regarding hybrid coronary revascularization, we conducted the CREST randomized trial to compare 3 revascularization strategies: conventional CABG, multi-vessel PCI, and hybrid coronary revascularization. In the hospital period, the expected lowest number of complications occurred during PCI. Up to 5 years, MACE was comparable in all 3 study groups. The same can be said about patient survival. The residual myocardial ischemia, according to SPECT, was also comparable. So, in conclude, mid-cap with thoracoscopic assistance have better in-hospital results. Hybrid coronary revascularization has demonstrated comparable results with conventional CABG and multi-vessel PCI in the long-term follow-up. Thank you for the attention.
Thank you very much, and thank you for being very prompt and on time. Any questions for Dr. Popov? You've been doing the mid-cap procedure pretty much one of the early people doing it in Moscow, in the Ravishvili
Yes.
Center, yeah.
I was in the beginning.
In the beginning.
Yes.
And did you start thoracoscopically, or were you first direct vision and then you moved to thoracoscopic?
It was the direct vision in first stages, and next we use thoracoscopic assistant. We tried to perform endoscopic CABG, endoscopic and the CABG.
Yep.
You know, Aladdin.
Yilmaz, yeah.
Yes, Yilmaz, yes.
He passed away, rest in peace. Yeah.
Yes. but it's not so easy. It's pretty much challenging procedure.
Very much so. And his procedure was on pump with an arrested heart, correct?
Yeah. And now it's stagnated in our center. Many reasons for that.
Question here?
Yeah, just to clarify, you're using the thoracoscope for your visualization, so you're looking at your thoracoscopic screen, but you're sewing through the mid-cab incision. Is that correct?
Yes, sir. Yes, it's a very good option because we use thoracoscope, visualization of LED line, LED, and next put in a needle, and through the needle we use approach.
I've thought of that many times.
It's good
I
option.
never knew
Very good
anybody
option.
who had done it.
Yeah, it probably takes a little practice too, because
Well,
it's a different view.
It's a different view. You get the light at
Yes, of
first.
course,
You
of
get the light through the direct vision, and then gradually you can get used to looking at both. And then, but that's a very nice technique.
And if you have 3D,
very nice option. Yes, very nice.
You're
option.
using 2D or 3D?
Sorry?
2-dimensional or 3-dimensional scope? 2D?
2D,
yeah. If you had a 3D, it would be even better.
2D because we have 3D, but we use 3D only for mitrals.
I see.
Mitrals, yes.
Yeah, I think that's one way to simplify the
Normally
mid-cap procedure.
2D.
Very good. Thank you very much. So thank you all for attending. I think it's time to conclude our session. Dr. Damiano's been pacing in the back over there, and he's going to kick us all out for the next session. So stay if you want to hear about AFib and coronary surgery. Thank you very much. Thank you very much.